Okay, when I say to you COVID, what is the first thing you do every time we talk about a disease? Right? For every infection. Okay, so if you haven't started studying infectious disease, here's how I want you to start organizing infectious disease. I want you to see it from the bug's point of view, see it from the patient's point of view, and then see it from the doctor's point of view. Okay? So this is going to be a single-stranded RNA which is not enveloped. And so every time you say virus, viruses have to have proteins to attach to the cell membrane, right? So every time you do an infection, you talk about reservoir. So where do we get our COVID from? It's person to person. And how do we do it? It's just like every other flu, it's by air droplets. However you want to talk about big ones and small ones, that's a good discussion. Then you say, okay, great. Then you say, tell me about the pathophys. Now at this point, we're talking about it from the organism's perspective. What do you attach to?
Respiratory epithelium.
Okay, that's fine, but I'm not going to accept it. True, but not a good answer.
Angiotensin II receptors.
Right. And now all of a sudden it doesn't matter to specify which cell, it's any cell with an ACE2. Now when we do that, now we can walk through what's going to happen. So the first cell that it's going to attach to is going to be nasopharynx. So what symptoms is that going to give me?
Congestion.
Right, runny nose, and now I'm starting to get a bit of a drippy cough and maybe a sore throat. The next thing it's going to go down is all the way down the tree, and it doesn't have to. No flu has to go all the way to the lung. It can stop anywhere it wants. So every time you say URI and lower respiratory infection, it's a false distinction. It means you're not thinking through this natural history where we're going to talk about time and the organism. So it starts in the nasopharynx, and then it can go down as far down the tree as it wants. So it's going to go to there, to the bronchus. And now what are we going to have?
Bronchitis.
Yes, that's right. So cough and wheezing, right? And then we're going to go down to the lung. So when I say the lung and I draw an alveolus, how many cells do you have to draw? Well, you've got to do a type 1 pneumocyte. You got to do a type 2 pneumocyte. You got to do an endothelial cell. And I'll look at all the other cells I'm going to add in here, plus a pericyte, plus our inflammatory cells. So our resident macrophages and our, what are the two cells that respond to DAMPs and PAMPs?
Monocytes and basophils, you said?
Yeah, basophils come from the blood, so the resident cell is going to be a mast cell. So now we've set up what's going to happen, but what we haven't talked about is how is this patient present? So here's what's fantastically different about this disease. We starting here, this is going to be day 1. When we're here, we're down to about day 7. And now they go to the doctor because they have an influenza-like illness. Now we're going to talk about the second thing that makes this different. And that second thing is the happy hypoxic. And you can see I always like nice sticky little things that make it easy to understand. What does that mean, the happy hypoxics? Have you guys seen any of these in the ER yet?
No, but I think that because we're now with the lung, we're affecting the alveoli, we probably are having a lower oxygen saturation.
Brilliant. So here I have a patient that they're not complaining about shortness of breath. It's just all this spectrum of influenza-like illness. But when you look at their SaO2 is in failure. And every doctor that saw this went, they couldn't friggin' believe this. But if you take a look at the lung and I look in the lung, what do I find? all I find is edema. And here's what you're just not going to be able to wrap your brain around. No inflammation. And the reason I'm so familiar with this was about the beginning of April, I was asked to join a group out of MIT who were working through what they thought was going to be one of the really important understandings of this disease was the role of famotidine. Because what they found in China was there was a group of people that had better survival when they looked at big data. And the group that did better was a group of poor, old males who had heartburn. What? Well, you can think this through. The risk factors for COVID is age and maleness are both negative markers. So when they looked in the mortality, that was a group that really stood out for mortality. But when they said, what's about the heartburn, the reason they had to be poor was because they couldn't afford cimetidine. And you know what's a lot cheaper? Pepsid. Pepsid's a lot cheaper. So all the poor people took famotidine and had a survival benefit. And that was what MIT asked me to come and join them for clinical pathologic correlation. And this is what was so remarkable to me. And so this sort of became the basis of our whole group's discussion was they did the pharm and the famotidine, and I was talking about what I was seeing in the path. At day 7, we had these extraordinary 2 cases out of China in which they'd been resecting what they thought were normal people for lung cancer, not realizing they were asymptomatic COVID. And when you looked at the lungs, guess what they had in their lungs? That ain't ARDS. That is not ARDS. And so when you look down this list and you say, okay, I get it. I'm looking at the ACE2s. But what am I looking for the famotidines? What does it block? It inhibits?
H2?
You've got that right. So all of a sudden, we went looking for cells with H2. And guess which cell has it? Well, all of them. But which cell is going to explain this? Okay, walk me through this understanding then. How does the mast cell get me to the edema picture?
Causes, the histamine causes vasodilation.
And you get edema. Ruber, tumor, Calor, Doler. There's my friggin' tumor, isn't it? So we actually have a paper out in which we are saying what we're not talking about is not talking about day 14, right? Day 14 at the end of the 2nd week, there's my ARDS. I get it. No one's objecting to the cytokine storm. But what we're saying is what leads to that? Because remember, mast cells have over 100 different proteins. So what happens now if I interrupt that mast cell degranulation? And that's our argument. We believe that interrupting the famotidine interrupting mast cell degranulation is a component of this disease. And then just to show you how aggravating galldarn politics is, so we had this big study all set to go in the Northwell system in New York that had all these early stuff. And you know what happened to our study? Stupid, everyone got involved in politics with the anti-malarial use. And after that study came out of Singapore saying, it's no good, everyone stopped all their patients, which included all of our famotidine patients. So now we don't have enough patients to do our study. But so we can't prove that we're right. But there is a pretty good study out of Mass General stating they found that. So when we saw the list this weekend of all the drugs the president was on, guess which one of his drugs was? So we were all... So when you ask me, Richard, what I think the difference between a doctor and a PA is, I think a doctor, as I was saying to Melissa, a doctor can understand change. So if I came in and said, hey, listen, Richard, no one knows what's going on with COVID, but you really want to differentiate week 1 from week 2, because right in here, I think we're seeing something unique I've never seen in any other virus, which is this pulmonary edema. And these patients come in with the flu. How would you recognize that, Richard? You can do your SATs, but if you didn't have a pulse oximeter, how would you do it? Get them to climb some stairs. Get them to climb some stairs. They just crash about stair 4. They just realize they're not stressing their system, so they don't know how bad it is.
Yeah, but to your point, like we know to look for that kind of stuff.
Right, but think how different it is for you, for me to walk through the mass and you go, you know, that makes really good sense until we get the studies. That seems pretty innocent. That's a safe thing to add. That makes sense to me. I'm going to do it. Whereas the PA is just going to do it because it's on the list. But we still don't know if famotidine is right. Okay, so one of the things you've now learned is there's a whole thing you can see in viral infections in which the disease isn't the virus, it's mast cell degranulation. And there are any number of viruses in which it's the second infection of the virus where antibodies cause mast cell degranulation that becomes the disease. And so now you know to look for this unique phenomenon of mast cell degranulation as a unique finding in it. So when you ask me what I think the difference between a doctor and a PA is, I think it's the ability to cope with change. And the other thing I would demand of physicians is critical thinking, so they can look through new studies and decide which changes they should bring into their systems. Good story, hey? All right, so yeah, so when you take a look now at your COVIDs, start following loss of smell is very distinctive and really cool. The second thing to go looking for, though, is not the ARDS. That's an end-stage common end pathway. We all get that. Look for that end of the first week, look for that happy hypoxic. That's quite distinctive to this. Okay, so here we go. Nice little break to the morning. Let's do our first case. We're continuing with endocrine. Okay, what does the age tell you?
Endocrine or autoimmune?
Yeah, right, if it's going to be that at all. What does my gender tell me?
Same.
Not much, right? What's my time frame?
This is a couple, yeah.
Go ahead.
This is relatively recent and started following a traumatic incident.
Right.
And so the evidence of polyuria and polydipsia.
Right. So now find your chief complaint, right? Nice. And that's going to be polyuria and polydipsia. Good. Remember, the whole point of a chief complaint is a differential diagnosis by organ system.
Yeah.
Okay, so go ahead. What are my organs?
The organs, well, the renal system, for one. I would say the central nervous system, for another. And I would just say psychiatric, but that's endocrine. But we consider psychiatric.
Nope, I think psych is great. Okay, everyone happy with that? So let's go through and let's at least get rid of the one we can get rid of. Which cell in the endocrine system leads to polyuria, polydipsia?
Beta pancreatic.
So good. That's so good. Nice. Because that was a really, I did as awkwardly as I could to see if you could do it. So there's going to be my beta cell, right? So what are my two common patterns of diabetes?
You mean like type 1 and type 2?
Yeah. Who do we think of?
So the type 1, it's an autoimmune process where you're attacking. Oh, historically it was always little kids, but it can be anyone really.
But remember, everything isn't equally important in medicine.
Right.
So when you're doing practical statistics, anything that's more than 90% is all.
Okay.
Anything that's less than 10% is none until it doesn't work out. Okay? And so you can sort of think of that as a tone of voice. Well, I had a diabetic. 10-year-old boy? Yep. Well, I had a type 1 diabetic. A 68-year-old woman. Really? Mm. That's how you know that you've got the rhythm of a disease, is when you know to go, when you know to go, wow. Mm. That's sort of the 90-10 rule in medicine. So type 1, that's going to be my 10-year-old boy, right? And my type 2?
Overweight, middle-aged.
Okay, but not just overweight.
I mean, they have insulin resistance, right? So
Yeah, but that's a very specific phenotype. It's not just overweight.
Sedentary.
Oh, anyone? What phenotype is insulin resistance? Which would you rather have, Melissa? Would you rather know their BMI or their belt size?
Belt size.
Right. Right? So it's not overweight per se as much as it's going to be apple configuration, right? They look like an apple, not a pear.
Like central obesity?
Yeah, exactly right. Belt size is more important than big. So the females in my family, tragically, have short legs and very large buttocks and thick thighs. But of course, they live to be 900 because being pear-shaped doesn't correlate to this thing. Okay, so when you think of every time you start a disease, you always have a little picture in your mind of what it should be, so you know whether to go ah or huh. That tells you understand who it is. Okay, so I've got to rule out this one, which is going to be my osmotic. So that's just always where you start, right? Just a quick check to make sure it's not osmotic. And then we go into kidney, CNS, and psych. Okay, so where am I? So now I've got a chief complaint of polyuria, polydipsia. Remember, we've got to have a way of thinking about these organs. So what picture do you need when I talk about the structure? Where am I? When I say CNS, what organ am I in if it's disease? You know it. It's not a trick question. It's just thinking out loud here. Well, it's going to be ADH, right? So it's going to be my posterior pituitary. Every time I give you an anatomical structure, we're right back to region, surface, internal, and so on, right? Every time you do an organ, go and do the structure. So when I say, tell me about the structure of the CNS, you need a picture. And this is one of the 3 or 4 mandatory images you have to have in your brain. This is going to be midline CNS. You've got to be able to do the midline head, okay? So watch how easy this is to do. Go do it. I mean, I know it looks really easy when I do it. It's going to take you 10 tries, and then you'll always have it. I always start with the structure in the brain. I always feel really confident about the midline. And that's going to be my corpus callosum. And into that corpus callosum, then, I'm going to build in the next structure below it, which is going to be my fornix, part of the reticular activating system. And when I've done these 2 structures, look what I can do now. I can come down and I can draw my optic nerve chiasma. Now, you know the pituitary has to be beneath it. Otherwise, how could an adenoma come up and compress it, right? So here comes my pituitary adenoma. And then what's my next structure? Mammillary bodies. And then I'm going to come along here and I'm going to start my midbrain to my pons decussation and then my medulla. So there's my midbrain, there's my pons decussation, and there's my medulla. Okay, well, let's just finish it up at the back, shall we? We're going to come down here and there's the pineal gland. That's then going to come into my tectum and then off into my cerebellum. And when you say, okay, hashtag make me care, well, you can see there's lots of really good things I can do here. The first thing I'm going to draw you is an orifice into my lateral ventricles. So that's going to be my foramen of Monroe. So you know this has to be the thalamus. Well, if it's below the thalamus, I'm going to call it the hypothalamus. That makes great sense. And I'm going to take my pituitary and I'm going to divide it into anterior and posterior. Okay, who walks in the door at number 1? This is my mammillary body. Who walks in the door? Acute and chronic.
Wernicke-Korsakoff.
Okay, Wernicke's acute. What is it?
Ophthalmoplegia, ataxia, and dementia.
Brilliant. And what's Korsakoff?
Confabulations.
Okay, that's really nicely done. Okay, so there's going to be my B1 deficiencies. Who walks in the door with pineal?
Can't look up.
Okay, so that's sunset eyes, and that's part of what syndrome?
Fair now.
Paranoid.
Very nice. Who walks in the door? What do they complain of?
Blurry
Could be
vision.
visual, so it could be diplopia. But what else you're looking for? Because look at the anatomy. What is this thing right here?
Headaches.
That's right. Absolutely, that's right. Because there's my aqueduct. And if it gets big enough, it's going to occlude it. Raised, it's going to be a non-communicating hydrocephalus, and they'll get headaches. That was really nice, Melissa, by the way. That was really well done. Okay, who's going to walk in the door with cerebellum?
Ataxia.
Right?
Headache.
Right. So tell me about the difference when I say neoplasms, adult and children. What's the difference? Go. Big picture story.
Adult is usually above the tectum. And
Brilliant. Right? So adults are supratentorial. Children are infratentorial. So if children are going to present with cerebellar tumors, how do they present? Ataxia and
headaches, hydrocephalus.
headaches, right? So you have any little kid presents with ataxia and morning headaches, yeah, that's just terrible. Okay, big picture adults. What's the commonest malignancy in the adult brain?
Glioblastoma.
Glioblastoma.
Metastatic. Oh, don't you, me. How do you tell the difference between...
It's always the trick answer.
It's not a trick answer. It's a way of thinking. Okay? So when I say to you, someone presents with the 3 cardinal symptoms of CNS malignancy, which are, of course,
Headache.
seizures, and then loss of function forever it's destroyed. The first thing you're going to think of is what?
Metastasis.
Metastatic. And how, in big picture story, how do you tell primary from metastatic?
Multiple lesions.
Absolutely, right? Multiple lesions, metastatic. And what's going to be your commonest primary, Alex? Okay.
Lung.
No, there's a principle. There's always I don't ever learn lists. So if I know the answer, you know, pretty sure there's an easy principle, right? Okay. Whenever you say neoplasm, in your mind, you're always going to say aggressive indolent. That's just how you think of neoplasms. Aggressive indolent. If it's not one of those, you go, huh? So when I say aggressive, what is the rhythm of an aggressive tumor? Give me the time frame. Oh, 8 to 14 weeks. You know, if someone's had something for 2 to 4 months, that's the right time frame for an aggressive malignancy. What's the right time frame for an indolent malignancy? 1 to 2 years. So if I said to you, follicular lymphomas are a classic indolent lymphoma, and you find that old lady that's had that bump there for 2 years, what's your bet? Right? That's indolent. That's going to be follicular for sure. So whenever you think about things, putting the rhythm of disease really helps. Age, gender, time frame. So when I say to you, if you're if you're metastatic to the brain, do you think you're aggressive or indolent?
Aggressive.
No kidding, right? I mean, that's death. That's death on a stick, okay? So when I say to you, you can just knock them off the top of your head. What are the 5 commonest causes of death in cancer?
Lung. Prostate or breast. Colon.
Pancreas.
Pancreatic.
So when I say to you, what do you think the commonest causes of metastatic disease are? You just start with the aggressive one. If they kill you, they must be pretty aggressive.
That's why I said lung.
Right? So that's always a good, you don't need to know the list. If you just know what you die of, pretty sure that's a common end pathway. And then there's a couple that tend to be a little bit brain centric. Just, you know, I don't think you need to know it, but you've heard it. Multiple melanomas tend to be, and renals tend to be, but they're aggressive, so that's not a surprise. So what is the commonest malignancy in lung?
No. Oh,
Squamous.
No, metastatic. How do you tell primary from secondary?
Same thing, multiple
Yeah.
lesions.
Yep. What's the commonest malignancy of liver?
Metastatic,
It is. And how do you tell primary from secondary?
multiple lesions.
Huh. What's the commonest malignancy of eye?
Metastatic,
It is. And how do you tell primary from secondary?
multiple lesions.
Right? Okay, so it's just one of those universal principles that metastatic is really common because remember, we have 600,000 deaths from cancer every year. And they're multiple, and then you say what it's going to be, pick an aggressive cancer. If it's not, you go, wow, okay, that's pretty interesting. Okay, happy with that story? Okay, so when I say cancer of the brain, adult children are different, supratentorial, infotentorial, and your instinct always with the brain is going to be, it's going to be metastatic, especially if they're over 65. Good? Okay. Now you say, okay, what else can I do with this picture? We're obviously going to come to endocrine in a sec, but what else can I do with this picture? Remember we talked about if I'm hypotensive, where do the baroreceptors report to? Wow, crickets. Someone hasn't been drawing their pictures out. Okay, remember that my carotids is the glossopharyngeal. Oh, you mean this one right here, 9. And my aortic arch is my
10.
vagus. Oh, you mean right there, number 10. And they're going to report right here to my nucleus tractus solitarius. And remember, where does my sympathetic nervous system start? It starts at T1. Oh, you mean right where the medulla becomes the spinal cord? Yeah, like that. So then this becomes my cervical ganglion, and there's the start of my sympathetic nervous system. So you can actually start organizing other things. The other thing that's going to come up later as you start doing more cancers is going to be your area postrema for vomiting. So that's the last area in there. You go, that's a really busy area. You just sort of want to think about it because you're going to see it a lot in your life. Okay, everyone happy with this discussion? So what we want to do now is let's go do our endocrine bit here. Okay, so let's blow this up so that we can see how this is going to work. So there's going to be my bifurcation, and then we're going to come down here. There's going to be my anterior, and then there's going to be my posterior, and off and out, and this is going to be my hypothalamus. The first thing we want to talk about as we're building our structural discussion is I want to ask you about Sheehan syndrome. Okay, so you've got your primip. She's got a little bit of an accreta. With me? And you give that cord a little tug. Yeah, we all give it a little tug. And sure as hell, she just bleeds out a liter and you have to transfer 2 units. So why is it the anterior, not the posterior?
Because the anterior pituitary it's going to be receiving a blood supply from, it's glandular tissue, and it's going to require more of
okay, that's very nice.
demand.
I like that a lot. So we've seen an anterior hyperplasia. So when we do our little picture of supply demand, right, it has an increase in demand. I like that a lot. Now, the other side is, tell me about the supply, Richard.
I couldn't tell you what the supply is.
Okay, and this is one of these really big ideas that you're never going to quite ever recover from. Because what you've got to understand is everything is run through the hypothalamus. Every friggin' thing that happens on the outside world happens and is regulated by the hypothalamus. So this is the great external, internal connector is right here in the hypothalamus. It is so profound that if you take a little kid and you put them in a closet and you keep them perfectly healthy, they're dwarfs because the hypothalamus won't secrete growth hormone. If you take a female and you put her in a really stressful environment, like let's say med school, she will start having abnormal menses because the hypothalamus is going to modify its gonadotropin releasing hormones. every one of you, can we use cortisol as a measure of your body's perception of your emotional stress?
Yes.
Abso-friggin-lutely you can. Well, who made that decision? Oh, you mean the hypothalamus that does everything? When we socially bond, what is the social bonding hormone?
Oxytocin.
Where does that come from? Where
The
everything
hypothalamus.
comes from, the friggin' hypothalamus. So it turns out even your marriage depends on your hypothalamus properly signaling social bonding. So every time you're taking your psychosocial cultural human and you're translating it to the biomachine, where are you translating it to first? The friggin' hypothalamus. Okay? But here's the bitch. The hypothalamus is part of the CNS, and the CNS is completely separate from the body because there's my dura. Well, that's awkward, isn't it? When you want to signal all these pathways, temperature, stress, bonding, reproduction, everything that you can imagine coming through it, appetite, growth size, protein synthesis, everything in the body comes out. How do you signal from these small number of cells in the hypothalamus? How do they signal the whole friggin' body? If you take your gonadotropin releasing cells, you know how many there are in the whole hypothalamus? 8,000 friggin' cells. That's it. Your whole baby hung on the correct decision of 8,000 crappy cells. Just blows your mind. So how are they going to be in a sequestered system? How are they going to signal to the body without it being diluted? There's the bioengineering problem. And this is how the body does it. You come up here and you start with whatever various nuclei you want. I bet there's one here called the arcuate because it's shaped like an arc. I bet there is. And I bet there's one up here beside the ventricle because here's my thalamus up here. So I bet the ventricles are right there. So I bet I'm going to call that one the paraventricular. I bet you are. And when they have to signal, watch what they do. They don't cross from the brain to the body. They don't. They come right down here and they stop right there. If you're signaling to the anterior pituitary, you don't leave the brain. And so this is where they're going to drop off all of their releasing hormones. It's got a name. This is my median eminence. So how is it going to be dropped off into just into the tissue? Literally comes to the end of the neuron and it just drops it off into space. How the heck is it going to signal the anterior pituitary? And therein lies the second story of our Sheehan's, okay? Watch this. Down here, this is going to be my inferior hypophyseal artery. And here, this is going to be my superior hypophyseal. And all of a sudden you go, oh, good Lord, this blood supply is going to come down here. This is going to be capillaries. So all these little capillaries right here are going to connect up and come down here as a portal system. Remember, capillary to capillary is a portal system. So it turns out there's two portal systems. There's one from the gut to the liver to the body, and there's one from the hypothalamus to the median eminence to the anterior pituitary. And now you can see why this is great. It's very slow venous flow. It's very, very tight because it's going straight to the cells it wants the signal to be at. And then the pituitary is going to take all of these releasing and it's going to put all of these stimulating hormones. So it turns out you got to reorient your brain. In our hearts, we always think of endocrine as pituitary talking to the body. Yet the pituitary is just a dumb amplifier. It doesn't do or decide anything. It merely takes the releasing hormone and amplifies it to the body. And the way you're going to remember that is in Sheehan syndrome. Because if I drop the blood pressure from bleeding, what happens here in my posterior side? Well, that's under arterial pressure. So that might drop to 60 over zip. It's still alive. But what's going to happen over here when I'm at a venous pressure? Well, it's going to go to zip. So when you talk about there's an increase in demand, and then all of a sudden I get a decrease in supply, that's Sheehan syndrome. Happy with that story? So that reminds you of two things. First of all, how do I really tightly connect the hypothalamus, who decides everything, to a pituitary that's just a dumb amplifier? The answer is a really tight capillary plexus to a portal vein. And that's really unmasked when I get a hypotension from it. Okay, so we're playing with Sheehan syndrome here. Let's just finish it. So here's my Sheehan's, and all of a sudden, don't you see Sheehan's now? Can't you see it? You got these two arteries coming. You go, well, this will hang on there. Whoa, this is going to be really friggin' bad. And then you've got all these releasing hormones, right? Tell me how they affect the body. What's the first symptom you get from all those signals dropping? What's the first thing that shows up in that lady? Give me the order of the symptoms from this lady. First is going to be prolactin. She's not going to get her milk let down over 2 to 4 weeks. So that's going to be the first thing that you're watching, right? Happy with that? You'd all memorize that, so you all knew that. Here's what's going to be awkward. Yeah, so what's next? What are you looking for next in her? You ready for this? Go ahead.
Is it lethargy?
Yeah, okay, but tell me which one I'm looking for. Tell me which one I'm looking for. Which hormone? You can't just say lethargy, because that doesn't tell me. Remember, okay, so we'll talk about this in a sec, but give me the hormone.
Cortisol?
Yes, absolutely. And then what's going to be next?
Thyroid?
Not really. So now can you see your patient? Okay. Now when you're saying when I'm looking for my patient, this is going to be lactation. Now you can do your fatigue. But when I say cortisol, what are you always keying on? When I say low cortisol, what do you always say next? Always. And if you haven't got this in your head, Alex, now you've got it.
Pushing?
Low. When I say low cortisol, what do you look for, Alexander?
Hypertension?
Okay, walk me through that. Go mild, moderate, severe.
Well, you get it potentiates the sympathetic
Okay,
response.
but the patient,
With the patient.
if I have
Okay,
a
so-
mild Addison's, and I'm saying everything based around hypotension, what's the mildest expression of hypotension to look for?
Orthostatic?
Absolutely. Next,
Syncope?
nice. And next,
Shock?
collapse and death. Absolutely. And so you learned it with the most severe form, right? Which was Waterhouse-Friedrichsen. But that's just, of course it is that. You don't have to learn that. Of course that's how all severe cortisol. That's not even interesting. Okay? Happy with that story? So all the other things in cortisol are true, but the one that you live, die with is going to be your blood pressure, right? And then what are you going to look for in your lady with the FSH, LH? Yeah, they don't menstruate. Now, isn't that a better story? Doesn't that just work great? Can't you just see it? Okay. Is there a range of severity of your disease? You ready for this? Absolutely. You can have mild, moderate, or severe damage to the pituitary. The average length delay of diagnosis is 2 years. Because everyone just feels lousy, right? You know, the commonest story is going to be the woman's going to come in a year and go, man, I knew motherhood would be this bad. I didn't know it would be this bad. Tell me about your delivery. So it might be as subtle as, wait, she used to be a chipper, smiley, nice person. Now she's just flat. The average length of time is 2 years. So don't just do the dramatic. Yeah, if the milk doesn't let down, that's easy. But you can have all sorts of partials here. Okay, so that's what we've. So far now you can see this relationship. Hypothalamus does everything. It is tightly linked to the pituitary, which is in the body. So this is our great CNS somatic communication, and then the pituitary is just an amplifier. And you've got these two different blood supplies, and Sheehan teaches us that. Everyone happy with that? Okay. So we're doing the posterior pituitary in this one. So when we say, how do we think about the posterior pituitary? So that's going to come down. Here's my chiasma. Here's my anterior. Here's my posterior. So in this, we're going to start with our paraventricular and others, and it's going to come straight down and release my ADH, right? So now we're into this discussion of how do I know if she had trauma? So when you think of that head getting whacked, where is the whack most likely to have damaged your brain? If I gave you that MRI or the CT, the median, where are you going to look first?
Infundibulum.
Absolutely. That's a great, great answer. You're going to look at the isthmus. What's the difference between infundibulum and isthmus? There's no difference. All infundibulum does is it means funnel shaped. So the original people were all Latin and Greek guys, so they named everything Latin and Greek. So that's where infundibulum comes from, but it's also the same as isthmus. So don't get confused on that. You see it flip back and forth a lot. It's really confusing till you hear it once. Yeah, so that's the commonest place to transect it, and then it doesn't come down. Okay, so when I say ADH, what are you going to think of next? What's the mechanism of action?
Ion channels, the collecting duct.
Okay, so we're going to draw a nephron, right? And it's going to be right there. There's my ADH receptor. What does it do?
Increases aquaporin 2.
Brilliant. I love that. Yep. So there's my aquaporin 2. Yep.
And increases water reabsorption.
How?
You have increased flow rate. You have already a gradient set up, so you add more water channels. Pardon me?
Where does that gradient come from?
The countercurrent.
Nice.
The sodium 2 chloride, potassium.
Brilliant. Everyone happy with all that? Okay. So when we talk about the big picture endocrine, if you're talking about how do I think about the endocrine system? The endocrine system is how does the biomachine regulate? And there are 3 great ways you can regulate things in the body. The commonest by far is going to be feedback. That's how most systems work. And so that's exactly how you're going to think about this system. You're going to think about the hypothalamus, which is going to releasing hormones to the pituitary. And the pituitary is going to release stimulating hormones to the organ. And the organ is going to produce a hormone that's going to inhibit. So every time we start with endocrine, you're going to set up a feedback system. And there's only 2 systemic systems that don't go through the hypothalamus. There's only 2. The exceptions of this are going to be 1, which was calcium, phosphorus, PTH. That's an independent system. And what's my other independent system? Okay. So every time you set up endocrine, you're always going to set up in your mind, you're going to go HP and then organ. So what are the other great ways of doing it? The other great pathways to think about is going to be signal. And a really good example, which we've done already, has been like DAMPs and PAMPs. Right? That's how we set up our whole immune response. That system will continue to amplify until it shuts down. Another good example is going to be, so there's inflammation. Second one's going to be coag. Right? So that's going to be our great tissue factor signal. And then the key regulator of coagulation at the factor level, there's going to be platelets, but the big one's going to be thrombin. everything goes through thrombin. Apoptosis is not a feedback system, it's a signal system. And then the last way to think about this is going to be constitutional. Constitution means the body makes a set amount of signal and you get what you get. And the classic example of that is going to be TPO to megakaryocytes. The liver just makes a fixed amount of TPO and your megakaryocytes take it and internalize it and create platelets from it. And that's why you see such a wide range in platelets. 140 to 420,000 is a normal range, because we all have these very different signals and we don't sort of have a common place to do it. So when I say endocrine, you're going to say feedback. So when I say, good, tell me how this is going to go for polyuria, polydipsia, you're going to do what test to test this feedback mechanism? Water deprivation. Everyone know how that works? Everyone happy with water deprivation? All right. You can ask any information you want. This is not meant to pimp you.
So we're back to the patient who's, after water deprivation, we have urine osmolarity that's still relatively high. And it's evidence that we're not getting vasopressin. Based off of that, we would give them desmopressin to see if there's a drop in the urine osmolarity.
Excellent. Every time you set these up in your mind, you're going to take these and you're going to, in your mind, until you've done enough of them, you're going to literally draw it out. So when you do your water deprivation test, the key fact that you need here is, what is normal serum?
290.
Right? So anytime you see osmolality, you're always going to compare it to serum. So here's going to be a drop in our water, right? And then you're going to say, what is my urine osmolality? Right? If it is greater than, pick a number that looks convincing. If it's greater than 500, then this is going to be psychiatric. But if it stays around 300, you haven't got evidence of a working system. And now you have to decide, is it going to be hypothalamus pituitary or is it going to be kidney?
Why is it greater than 500 psychiatric?
Well, what would a normal system do as it runs out of water? In other words, I've done my water deprivation for 4 to 8 hours, Alex. What would my normal system do?
It would pull as much water back as possible.
So what happens to urine osmolality?
It'll go up.
That's
so
the
you're
trick.
not
Is, am I in serum or I'm in urine, right?
You're not talking primary polydipsia. You're talking not drinking psychiatrically.
Right. So this is polydipsia.
Wouldn't you have low urine osmolarity because you're just flooding your system with water?
That's right. And what happens when I don't give you any?
Got it. This is post.
This is proving that you have a working system. Isn't that great? Right? Isn't it great when you actually have to talk about something and do a picture of something and map out an algorithm? You learn it in a way that's just better, right? Because it's really easy to flip, am I in urine, am I in serum? Wait, aren't they got their teeth floating from? Yeah, I get all that. But we're starting with water deprivation. Nice. Happy? Okay. And then as Richard brilliantly said, we're now going to give them vasopressin. What does AVP stand for? So there's lots of ways of calling ADH. Remember when they first discovered it was through its V1 receptor effect. So that's why it became vasopressin. And then the commonest one we use clinically has got an arginine attached to it. So you'll often see it clinically written as arginine vasopressin, but it's just ADH. And then as Richard said, okay, show me what's going to happen, right? And we're going to see one of two things. It's going to be greater than 500, or it's still going to remain around 300. So it's greater than 500, just like Richard said, it's going to be central. And if it's about 300, it's going to be nephrogenic. So you can see how algorithms, because of this feedback picture that we have, you can see that algorithms with a picture of the feedback mechanism is how you're going to set up all of your endocrine. All of endocrine sets this way up. Okay? Happy? So when we say what's going to be next, we're going to have to see what our arginine vasopressin did, right? We assume that's what they would do next because they haven't shown a working system.
So this patient, they give them desmopressin and it goes up. So that would be evidence pointing to it being central diabetes insipidus.
And does that make perfect sense?
Yeah, given that this is likely secondary to trauma from the car crash that she was in.
Okay, so let's just, that's a fun one to do. But when I say what's the most common cause of central, it's trauma. What's the commonest trauma? Do you know? In other words, if I was going to write a legit real world question, what clinical picture would I take?
Shearing stress from like a forward displacement? I don't know.
Doesn't that just make perfect sense? When you go in and resect you do all your transsphenoidals, really hard to know exactly where you are. And you're using a cutting needle, really easy to cut off the infundibulum. So when
more
you get
common than NVC?
NVC.
MVC, motor vehicle collision, more common than car accident?
Yeah. Because generally speaking, that hard a whack in the head is going to smush your brain. It's not that you don't get lots of brain smushes. It's just that to it selectively to do hypothalamus pituitary infundibulum is pretty uncommon. Now, my bet is if you went to the third world where everyone rides motorcycles without helmets, I'll bet you'd get pretty good at it. But you take us who are mostly airbag seated in, just, you know, compared to pituitary adenomas, you're sticking a cutting needle right up through the sphenoid. Okay? So if you ding the infundibulum, how long is it going to be before you see your polyuria, polydipsia? Because you're going to do this surgery, right? It's going to be days. And most of the time, it's not a permanent trauma. Most of the time, it's bruising, edema, you bled near it. Most of the time, it'll spontaneously correct over a few weeks. So how are you going to treat it?
You give them desmopressin.
How do you do that?
In a pill. Oh.
Isn't that cool? So they can actually follow their own thirst patterns, and they can actually carry their little nasal spray and they can treat themselves with it. Okay, who's the commonest person for psychogenic polydipsia? It's usually an early schizophrenia. Okay, and so what's a common unmasking event is pregnancy. So you're going to see you're going to see pregnant women become quite more severe with their schizophrenia during the stress of delivery and baby care. So that's when you see polydipsia in that group, that's a common way for that to present. Just to finish this up then, when we say nephrogenic, what are the two commonest causes of nephrogenic?
Lithium is one.
Always. Anytime you say kidney, you're always going to say lithium. What's the other one you always say with it?
Carbamazepine? That's probably way wrong.
Thiazides.
Okay.
Anytime you say kidney, you're always going to throw in those two guys. Okay, so what we've introduced this morning is we've talked about when you think about the endocrine system, everything is hypothalamus, pituitary organ on a feedback system, except for glucose and calcium. And when we say, tell me about the hypothalamus, I'd underweighted it in my life. Remember, everything goes through the hypothalamus, and then it has that really tight portal connection through the median eminence. And all the pituitary is an amplifier. And because we can set up these feedback mechanisms, we're going to set all of our diagnostic trees off algorithms. So this is the first of many algorithms we're just going to go through because it's a really natural way to set up feedback monitoring.